Good evening, ladies and gentlemen. Thank you for joining both the Jamaica Cancer Society and Baptist Health for this evening's presentation by Dr. Jane Mendez, Chief of Breast Surgery, Miami Cancer Institute. Thank you for joining us and welcome. It's been a pleasure for us at the Cancer Society to share with Baptist Health how we value the partnership and the relationship which we have with this fine institution of doctors and persons who are at the ready to assist persons who are diagnosed with breast cancer and other cancers. The Society, the Jamaica Cancer Society, would like to take the opportunity to express our sincere appreciation and commitment to Baptist Health and our vow that we will continue to have this relationship as long as it is possible to ensure that we provide to the public relevant, updated, and pertinent information as it relates to cancer, breast, prostate, cervical, and other forms of cancers that affect the entire population of the Caribbean, as well as Jamaica in particular. With this in mind, we thank you again for joining us, and we hope that this information this evening will be filled with information that will assist everyone in understanding more clearly what and how breast cancer has been impacted by COVID-19. Thank you so much.
Thank you, Shelley-Ann, for the introduction. It is a pleasure to be here. Good evening, distinguished guests. Thank you for joining us today. I'm Dr. Galit Hakim, Vice President of International Healthcare Partnerships. And it is my distinct pleasure to welcome all of you to this informative presentation. I want to begin by thanking Mr. Michael Leslie, Acting Executive Director of the Jamaican Cancer Society, Shelley-Ann Brown, Fundraising and Public Relations Officer, and the Jamaica Cancer Society for facilitating this opportunity for Baptist Health International to provide you with information on breast cancer and COVID-19. Baptist Health has grown to be one of the largest healthcare organizations in South Florida, consistently ranked as one of the best companies to work for and one of the most ethical companies in the country. Baptist Health has invested in buildings and international operations many years ago, and today has one of the largest hospital-based international healthcare programs in the US, with more than 14,000 patient visits each year for over 100 countries. At Baptist Health International, our team strives every day to continue to support our mission and provide the highest level of attention to our patients and physician colleagues, both at home and abroad. With a welcoming multilingual and multicultural staff committed to providing a first-class patient-centered experience, we take pride in welcoming patients to our city and working closely with physicians to meet their needs and expectations. From air ambulance to commercial transfers to booking accommodations, Baptist Health International offers 24-hour personalized service to our international guests. Our organization is truly a global leader in healthcare, the premier provider in this region for compassionate quality care. Now it is my pleasure to introduce Dr. Jane Mendez, who is the Chief of Breast Surgery at Miami Cancer Institute. Dr. Mendez is a board-certified surgical oncologist and chief of the breast surgery at Miami Cancer Institute, part of Baptist Health, South Florida. She specializes in the treatment of breast cancer and performs all types of breast surgical procedures. Dr. Mendez received her medical training at Mount Sinai School of Medicine in New York. She completed a residency in surgery at Mount Sinai Hospital in New York, followed by a fellowship in breast surgery at Memorial Sloan Kettering Cancer Center in New York. Some of Dr. Mendez's many honors include being past president of the Boston Medical Center Medical and Dental Society and staff, and her appointment to the governing board of Susan G. Komen, Massachusetts affiliate. She is a fellow of the American College of Surgeons and an active member of numerous professional societies, including the American Society of Breast Surgeons and the Society of Surgical Oncology. She has contributed to notable breast cancer research, and her findings have been widely published. She also has presented abstracts at numerous national and international symposiums and serves as an editorial board of the breast section of the Annals of Surgical Oncology. Dr. Mendez is fluent in English, Spanish, and French. Please let's give a warm welcome to Dr. Jane Mendez. Thank you, Dr. Mendez, for being with us today.
Thank you. It's my pleasure to be here. and spending this time with all of you while I get my presentation up. So thank you again for inviting me, Dr. Hakim, to be part of this important topic. So this evening, also thank you to the Jamaican Cancer Society for including me, as breast cancer is very dear to my heart. So this evening, I'd like to share some of the issues pertaining to breast cancer 2020, some of the treatment issues, prevention, and certainly COVID-19. So breast cancer, okay. Real life, let me go and see why this is not advancing. One moment, I'll get my presentation back up. So I have no financial disclosures for this evening's presentation, and it is a pleasure to be in Jamaica, even if it's just virtually. And I know that many of you from the Caribbean have also joined us this evening, some from the British Virgin Islands and Cayman. So all welcome. I can feel the calypso music in the background. So with that, our building is dressed in pink in commemoration of breast cancer awareness, as many other institutions around the globe are also recognizing the importance of breast cancer globally. This is the facade of our Miami Cancer Institute, Baptist Health, South Florida. It's all the services under one roof, including infusion services, radiation oncology, surgical services, fertility preservation, patient navigation, all the different components of the breast cancer and any cancer journey. But most importantly, we also address all the other very important components and the holistic approach to cancer treatment, including psychosocial services, integrative medicine, survivorship care, social work, nutrition, exercise, and even a boutique where you can buy your wigs and your prostheses as needed. So they've thought of everything. One of the most important assets of the Miami Cancer Institute is having the proton beam, which is one of only 14 throughout the United States of America. And our the radiation oncologist has every single modality available for care. So we try to see which is the most useful for the given patient to really maximize their cure. So we're very proud of our proton therapy center. With that, we also are only one of 4 institutions outside of the Northeast who have an alliance with Memorial Sloan Kettering Cancer Center. So our treatment protocols as well as research endeavors are aligned with Memorial Sloan Kettering Cancer Center, and we're very proud to be part of this alliance. With no further ado, this is our lobby, and right next to it is the entrance to our breast clinic, which is housed on the 2nd floor of a 4-story institute. And this evening, I'd like to discuss the breast cancer burden worldwide, discuss the importance of the multidisciplinary approach to breast cancer treatment, review some of the risk factors and prevention strategies, and ultimately some current and future challenges when it comes to breast cancer. If you come to think about it, every 2 minutes, a woman gets down with breast cancer in the United States. Imagine that's even less every minute if you go worldwide. We're all very familiar with the number 1 in 8, which is the risk of a woman developing breast invasive cancer during her lifetime. We also know that there's 42% higher breast cancer mortality rates in African American women as compared to white women. And we know as well that breast cancer is the number 1 cause of cancer death in Hispanic or Latino women. Put it in other words, 99% of breast cancer occur in women. It is the #1 cancer in women worldwide, second cause in cancer death in the American women. And nowadays, because of all the advancements and all the technology, we have over 3 million survivors of breast cancer in the United States alone. And if you take that number worldwide, that's even larger. The two main risk factors for breast cancer are being a woman and getting older. And the numbers here speak by themselves. As you can see, if you're by age 50, 1 of every 50 women will be diagnosed with breast cancer. When you're in your 70s, 1 of every 14. When you get one in your 80s, it's 1 out of 10. So even though we'd like to forget of the breast cancer, the older we get, actually the incidence increases. So even more important to take the necessary strategies as we get older, because we know the number is really high. These are the most recent statistics for the American Cancer Society, where you can see for 2020, 30% of the cancers women in the States, accounting for 266,000 women, were secondary to breast cancer. And second cause of cancer deaths this year alone, in the States alone, over 40,000 women will die secondary to breast cancer. And as you can see, the #1 cause of cancer mortality in women happens to be lung. And that's secondary to the increased smoking habits in women over the past few decades. But again, remember, breast cancer is not just for girls. 1% of breast cancers may occur in males. And usually stage for stage, the outcomes are very similar. However, since we don't have the same awareness about male breast cancer, they tend to get diagnosed at later stages of disease. So therefore, very important to know that especially in certain ethnic groups, male breast cancer is more common, and we really need to have a heightened index of awareness. And this is a myth that actually a lot of women have out there, and certainly you in the audience, 85% of breast cancer occurs sporadically. It means that nobody in your family has said, you're the first one. Only 10% occur familial, which is that you have a family history, but we have not been able to identify a mutation to explain that family history. And 5% are what we call hereditary, that we can really identify a mutation that we can act on, and that certainly predispose you to the breast cancer. So the vast majority, remember, 85%, you have nobody in your family, you happen to be the first one, sporadic. And it does not matter where you are around the globe. Breast cancer accounts for over 20% of cancers anywhere you are. North America, South America, Central America, Caribbean, Asia, Africa. It does not matter where you are. So it's certainly an issue of global public health concern that really behooves all of us to be part of this action. And actually applaud the Jamaica Cancer Society for their efforts. It was founded in 1955, with the idea to eliminate cancer as a major health care problem in Jamaica. And in getting ready for this presentation, I had the chance to speak to Julian a little bit to learn about how they're really offering free mammograms and free screening processes so that people cannot say no. It's getting to the community, aligning with the proper people in the community on the outreach that we know is so key in, obviously, in prevention and the elimination of cancer around the globe. Not only breast cancer, but also prostate cancer, cervical cancer, very common cancers that we know could be prevented, and early detection is key. So I applaud the society. And with that, we also know that depending upon where you are around the world, that really impacts your survival rates. If you're in a high income country, such as the United States, Canada, Western Europe, you're talking about 80% survival. Whereas if you're in a low income country, that number plummets to 40%. So certainly we might allude that to access to care, technology, education, prevention. There's so many factors And again, all of us are part of this crusade. So nobody would ever argue with me that when a woman feels a mass, it's an anxiety-provoking moment. They wanted it taken care of yesterday. There's a sense of urgency. First thing that comes to mind, I have cancer. So as healthcare providers and as patients, we have a fundamental task, and that is we cannot assume, and we have to determine whether that abnormality, whatever that might be, is it something benign or malignant? And that's when the process starts. So the gold standard as part of this process is the mammogram. And mammogram is the gold standard for screening. Certainly, sometimes we might complement that with an ultrasound, especially if somebody has very high breast density. And the ultrasound will complement it and give us a little bit more information so that we can determine what are the next steps for further evaluation of that particular abnormality. In this particular case, you can see there was a density that appeared to be very abnormal with irregular borders. And then they did the ultrasound that showed that it was a solid mass with very, very irregular shape. And that led to the needle biopsy that you can see here being inserted for minimal diagnosis and led to the diagnosis. 3D mammography has been an advancement. Certainly we have it available at our Baptist breast imaging facilities, and it has allowed us to kind of reconstruct the breast in a 3D dimension to detect abnormalities even earlier than the 2D mammography. So this is something that our centers are equipped with already to help us in diagnosing our patients. Breast MRI, wanted to say one or two words about it. Breast MRI is not a screening tool by any stretch of the imagination. Number one, it's very costly, and it has a very high percent of false positives, up to 24%. But in a very specific segment of the population, it will be a very useful tool, especially those patients who are at increased risk of breast cancer in excess of 20%, women who have known genetic mutations, and therefore that is considered to be part of their increased surveillance. And we can talk more about the indications for MRI, but it is certainly not a screening test, but a great tool that we can use for selected patients. And there's a lot of research going on. One thing that I wanted to talk about is the contrast enhanced mammography, which is something that is researched right now, trying to see if by injecting contrast, we can improve the ability to detect abnormalities through mammography, kind of a poor man's MRI. So that's again in the pipeline. But unfortunately, I have to say that for the time being, the big squeeze remains the gold standard. And currently, the recommendations for mammogram are to start at age 40 and yearly thereafter. Certainly, you have other risk factors that increase your risk. You definitely should have a conversation with primary care physician or your general practitioner to determine whether or not you need to start getting screened earlier because of your risk factors. And they may recommend a baseline between age 35 to 40. And if you are, there's no date by which you need to have your last mammogram. So provided you're healthy and you have good performance status, then certainly you should have your mammogram if you're willing to get treated if something is found. So I'd like to change gears a little bit now and talk more about the treatment component. And there's been a significant evolution from the times of the Holstedian principles down, when obviously the more you remove, the better it was. The larger, the better. The more aggressive, the better. To the more modern approach, which is a combination of what is called the multidisciplinary treatment, where we combine not only doing surgeries, but also the systemic approach. So all these individuals who are at the top of the slide, John Halsted, Umberto Veronesi, as well as Armando Giuliani, who's on the extreme right, they're the forefathers of modern breast surgery who challenged the concepts of doing these super radical procedures where the patients had their breast, their muscle, and all their lymph nodes removed, to the more current era where we know that not one size fits all. and where we know that we can do lumpectomy successfully, we can do sentinel lymph node biopsies, and still with great results. Nowadays, we know that if somebody has early stage breast cancer, they have a survival up to 98.5%. So again, early detection is key. And this is so because of all the multidisciplinary approach. And here at Miami Cancer Institute, we're so lucky that all these services are housed under one roof. I couldn't do my work as a surgeon without the help from all these different teams. You know, the medical oncology team, the radiation oncology team, the plastic surgeons, you know, the pathologists who are behind the scenes, the radiologists who help us with the imaging and the minimally invasive biopsies for diagnosis, and all the other comprehensive, really patient-centered approach, including genetic counseling, nutrition, exercise, psychological component, everything under one roof. Again, it takes a village for a cure, and you can clearly see it. But there's many ways to do it. Not everybody needs a mastectomy, not everybody needs chemotherapy. So this is now the challenge which comes now, which is sometimes patients receive chemo prior to surgery, sometimes surgery is first. Sometimes we might need endocrine therapy or the pills for those patients who are estrogen receptor positive, trying to shrink the tumors before surgery. We have a lot of options in terms of the chemotherapeutic options that we can offer. And again, not all biology of the cancers are the same. So we need to know what is best for that particular cancer. Like all patients are different, cancers are different. And we need to key component individualize the therapy. Because as I already said earlier, not one size fits all. And there's been a transition, and we have a much better understanding now over the past 50 years of the biologic heterogeneity of breast cancers. It is not, is it responsive to estrogen or not? There's also the triple negatives, which have been a challenge and are considered to be the holy grail within breast cancer. We have now the HER2 targeted tumors, so understanding that biology and all those differences have been critical. And one of the other greatest assets has been what we call the genomic profiling. Being able to send somebody's tumor tissue for analysis for certain genomic profiling to even figure out if they benefit from chemotherapy or not. Something like the recurrence score or something like the mamma print, which are ways that we can use clinically to help us decide whether the patient will benefit from chemotherapy or not. Because we know that at the end of the day, yes, we have some targets, but also with everything, we need to keep a balance. We need to keep a balance between maximizing the breast cancer cure with quality of life. Because with everything we do, there's risk and there's benefits. And even though I can provide a therapy, if it's going to cause significant sequela downstream, what have we gained? So we have become extremely critical of these equations, because at the end of the day, it is my job to reduce the collateral damage. If I know it's not going to help my patient or it's not going to improve their survival, why do it? Okay, and not only talking about healthcare costs in general, cost of human life, you know, and side effects and long-term side effects that might be associated with that treatment. So it's a very intricate conversation. Again, not all options apply equally to all patients, but it's really lengthy conversation, and we have to be extremely honest with the patients about what might be in it for them, because it is for their health and for their well-being. And Angelina Jolie, when she went public with her op-ed in the New York Times, that dates back to 2014. And that led to a significant explosion of genetic information and genetic testing that we didn't have before. And we're very privileged here at the Miami Cancer Institute that we have geneticists and multiple genetic counselors that really helped us. But after she went public, that has led to an increase in the bilateral mastectomies. It's become like the bilateral mastectomy pandemic. Everybody wants to get a bilateral mastectomy, even if they don't have a genetic mutation, and even if they know that it's not going to impact their overall survival. A lot of patients are choosing that. And I think it's secondary primarily, and I ask my patients why. Why do you choose to proceed with a bilateral mastectomy? This is the number one answer that I get from my patients. They want peace of mind, okay? Truthfully, it's never gonna be zero likelihood of the cancer coming back because there's still a likelihood of 2 to 5% of the cancer recurring after a mastectomy, but as close as they can get to that zero. And I think this trend is secondary to a multitude of factors. Number one, from the patient's standpoint, they might have fear of cancer. I already told you about peace of mind. They're worried about cancer recurrence. They have an overestimation of their risk, their age, their family history. Sometimes there are cultural biases that lead to this decision. They might not want radiation, and mastectomy might be the best option from them. And from the healthcare standpoint, you have the physicians who might not be that clear on their recommendations. They may have certain biases. They might have issues pertaining to knowledge gaps and not knowing that necessarily that's not what's best for that particular patient. The increased use of MRI has led to added anxiety because then you find other abnormalities and then they think the mastectomy might be better. And there's great geographic variation depending on the resources. Specifically, do you have a good plastic surgeon who can really then do an immediate reconstruction with acceptable cosmetic results? And if you add on top of that the media and how all these actresses and celebrities have really gone public with their own stories, and the availability of genetic testing and more women finding out that they have genetic mutations, not to talk about the cost and the increased complications. But this is a reality that I deal with every day. And it's surprising to me how many patients, despite being educated on the pros and cons, to choose to proceed with the bilateral mastectomy because it is their choice. And one of the things that we actually can offer to our patients, against selected patients, is what's called the nipple areolar sparing mastectomy. Whereas you can see, we preserve the whole envelope. It's just the scar to remove the area of the, the mastectomy through a small incision. We actually now even just do the lateral incision without anything around the nipple areolar complex so that we don't compromise the blood supply. But that's an option. There's been some question of whether this is something that is oncologically safe. But again, for selected patients, this will be a wonderful option, both from the oncologic as well as the cosmetic standpoint. There's certain criteria that we have to follow in terms of who's the right patient to have this type of procedure, both anatomically as well as oncologically. But this is something that we can discuss with some patients. And I also want to here to introduce, because of all this genetic testing, we have now introduced a new concept, the concept of previvorship, okay? So that would be when we know that with the genetic testing, we identify that you have a known mutation. And then being able to act with increased surveillance, increased prevention strategies, keeping you in that previvor stage and never develop the cancer. So actually this March, I was happy to open the breast cancer prevention clinic, specifically geared to these women who might have genetic mutations, who might have high-risk conditions from the pathologic standpoint, who might have a strong family history of breast cancer without a genetic mutation. They might have exposure to radiation in the past, any of those risk factors that really increase their risk, but to keep them in the previvor state by a combination of increased surveillance along with dietary, exercise, and just genetic assessment as needed. So this is an important concept that we would like to move forward. And another component that I wanted to bring up is the issue of the elderly, because this is the fastest growing segment of the population. So we've asked, do we have to be so aggressive in the elderly individuals that obviously certainly have other comorbidities that will impact their outcome? So certainly now we're not always checking the lymph nodes in the women who are 70 and older. We might not offer radiation, you have favorable characteristics. Again, trying to challenge the dogmas and trying to keep that balance that I alluded to earlier in terms of maximization of cure and quality of life. So now, I've talked to you about a lot of advances, technological, scientific, biologic. Increased awareness, absolutely. Since the inception of mammogram, we know that it works. However, we still have this black box, and this is still a challenge, which is we still don't really understand all the biology about breast cancer and all the different subtypes. And we also know that the overall risk of breast cancer is lower for Black American women compared to Caucasian women. However, the death rate or the mortality is higher. As we alluded to earlier, it's at 42% higher. We also know that Black women tend to be diagnosed at earlier ages and younger as compared to the Caucasian women. We also know that African American women tend to be diagnosed at later stages of disease and more advanced. And we know that Hispanic women tend also to be diagnosed at later stages. And why? Well, for many years, we've attributed a lot of these issues to secondary to socioeconomic cultural factors. You know, everything from prevention to survivorship, we know there's a myriad of obstacles and barriers that might account for these disparities. But we also know that there have been many published studies where even having the access to care, we still see some of these disparities. And the issue that comes in is we know that some of the triple negative breast cancers, which is the one that is considered most aggressive, is actually most commonly diagnosed in the African American women. And within that, the younger African American women. So this is not only socioeconomic cultural factors, but also biology seems to be playing a very important role in these disparities. So needless to say, we still have a lot of work to do pertaining to this issue, but at least we're getting closer to the root of the problem. And we know that every time a woman comes in through our doors at the Miami Cancer Institute, we cannot make any assumptions. You know, every woman comes with their own story, their own fears, their own concerns, their own ailments, their own medical problems. But our job is to do patient-centered care. As we like to say, high tech, high touch. You know, for me, even when somebody comes, I ask lots of questions because I'm not only interested in their breast cancer, I need to be about their whole well-being. And this is part of that patient-centered approach. So we know that when they come here, we know healthcare begins here. And I'm happy that we partner with all of you in this endeavor. But ultimately, healthcare begins with you and what you can do for your own health. We need to take charge. We need to take ownership of our own health, and we need to be accountable. And when it comes to breast cancer, one of the first things that we can do is breast self-exam. Be familiar with your body and be familiar with your changes. So that way you can detect minute changes that then will lead to your GP or your GYN. Because we know that 30% of breast cancers, it is the woman who first feels the lump. And then they take action. So do not underestimate the importance of knowing what's normal for you, so then you can seek a medical attention. If you see something, say something. Don't just let it be. And some of the things that you can look for are texture changes, skin changes, nipple retraction, nipple discharge, color changes, and dimpled skin, you know, because it does not always present like a mass. So you need to be familiar with what's normal for you, so then you know if there has been a change. And when it comes to other risk factors, I already mentioned age and gender. However, there's some other risk factors that are non-modifiable and some more that are non-modifiable. So besides age and gender, we also cannot change any personal history of breast cancer, any underlying pathologic condition that we have that predisposes us to breast cancer, any genetic mutation that we have certainly we can change that. Exposure to radiation, if you were in Chernobyl or Hiroshima and you were exposed to atomic bombs or radiation of that magnitude, having the period at a very early age or early menarche, or having your menopause at a late age because you've been exposed to estrogen for a much longer period of time, not having any children or nulliparity, or having your first child after age 30. All of these are factors that we know we cannot control. But the most interesting list is perhaps the one that we can control and the one that probably most people don't want to hear about, but the one that is most important, not only for breast cancer prevention, but also prevention of any ailment. Cardiovascular disease is also a significant problem in women. So one is weight control. Certainly, ideal body weight is critical, and there's no perfect diet. As I tell all my patients, it's more about moderation, how you prepare the foods that you eat, as there is no perfect diet. And we know that the more obese we are, the higher the estrogen levels, because the estrogen deposits itself in the adipose tissue or fat cells. So weight control is a very important component. No cigarette smoking, there's no direct link between breast cancer, cigarette smoking, as there is with lung cancer. But I already told you lung cancer is the #1 cause of cancer death in women in the United States. So I'm going to advise all my patients to refrain from cigarette smoking. When it comes to alcohol consumption, obviously moderation is also the key word. We think that red wines, it contains phenolic acids, what are supposed to be protective against breast cancer. You shouldn't have more than 1 drink per day at most. And obviously drink in moderation is a key word. Exercise, sedentary lifestyle is not good for anybody. And now certainly it's really hard to get to a gym or to a sports facility because of all the restrictions pertaining to COVID. But don't use as an excuse, walk around, walk upstairs instead of taking the elevators. Do whatever you can to get your heart rate up, because that's what's critical. Avoid ionizing radiation. Certainly that is only certain parts of the world where that might be an issue. And the last one listed here, which is hormonal replacement therapy, for years that had been controversial, but now we know that the chronic use of estrogen replacement therapy is indeed a risk factor for breast cancer. And I cannot tell you how many women still come to me now in 2020 and they have been taking the hormonal replacement therapy for 10, 15, 20 years, knowing the fact that it increases the risk. And how many times I need to tell them, speak to your gynecologist, look for other alternatives that are not hormonally based. So that's an area that we still have to do a lot of work. And now I wanted to take the opportunity to dispel some myths that abound out there. Breast cancer comes in the form of a lump. Certainly we know that's not true. It may come as some swelling, some changes in the nipples, some irritation or dimpling of the skin, some redness or the orange like skin, certainly bloody discharge or other discharge from your nipples. Sometimes it might present with a mass in the area of the underarm or the axilla. So certainly be vigilant, and if you see something, say something. The other myth is one that is not very popular, which is the caffeine. And do I have good news for you, or I don't? But I do. Enjoy your cup of coffee. First, because no causal relationship between caffeine and getting breast cancer. However, there is a link between caffeinated products and breast pain or mastectomy. So certainly when I have patients who come with fibrocystic changes and significant complaints of mastectomy, I'm going to have them refrain from all caffeinated products, coffee, sodas, tea, chocolate, because I know it can definitely exacerbate their symptomatology. When it comes to breast pain as well, another factor that I need to warn my patients about soy-based diets, as soy is a phytoestrogenic plant and may exacerbate their pain and their fibrocystic changes. but there's no causal relationship between caffeine and breast cancer. Another myth is that wearing antiperspirants increasing the risk of breast cancer. This is not true. Certainly along those lines, I've also heard about hair dyes and cell phones, but that's all no causal relationship. And breast implants, let it be saline or silicone, there's no proof that they're associated with the increased risk of breast cancer. However, again, another word of caution. Now we have data that there's a specific type of implant, the texturized type, that actually we have banned here at the Miami Cancer Institute and we don't use, which has been associated with a very rare form of anaplastic breast-associated lymphoma. It is not breast cancer, but it is a lymphoma. And any patient who had this type of implant placed should have it removed, because we know that in the long run, they might develop this type of lymphoma, which is extremely rare. But the breast implants, saline or silicone, are not associated with increased risk of breast cancer. So we need to know our lemons, and the lemons come in very different ways. Let it be a bump, a growing vein, sunken nipple, and fluid, let it be rest, nipple crusting, dimpling of the skin. Certainly know what's normal for you. And we ultimately know that the best defense is to breast cancer early. So obviously get your mammograms, and the outcomes should be excellent provided we have early detection. And some of the challenges ahead obviously have to do with that, which is that now, because of COVID-19, a lot of our patients are not following the screening guidelines. Since, I guess, over the past 7 months now, they have not gone to get their mammograms done. And what we've seen is delayed stages in terms of diagnosis. I cannot tell you how many women now come and I feel lymph nodes in the area of the axilla. So again, a more advanced stage. Some of these centers were closed for imaging, and even though now they're open and everybody's following the guidelines of social distancing and all the proper protection, there's still certain ambivalence on the patients to have their mammograms done. So ladies out there, do not let the fear get in the midst of getting your mammogram, because certainly it can be done safely, and it'll be worse to have a delayed or misdiagnosis. With that, we've had to do a lot of thinking outside of the box once COVID hit our grounds, in terms of many components of what we do every day. One was the surgical management options, healthcare delivery system strategies, and also enhanced supportive services. I cannot tell you, in the past 7 months, I have referred more of my patients to psychiatry or psychology than over the past 3.5 years. Between the issues of being diagnosed with a cancer, let it be financial distress, let it be isolation. It's been a very difficult time. And so I'm being very blessed to be able to provide those additional supportive services to our patients. And these are, early on when the pandemic struck, many different groups around the United States, including the American College of Radiology, American College of Surgeons, the American Society of Breast Surgeons, Society of Clinical Oncology, they all got together to come up with some of the recommendations given the pandemic in terms of how to treat the breast cancer patients. And it was extremely helpful in guiding us in how to do that. And it can be summarized basically in this slide, issues pertaining to safety, prioritization who really needed to get to the operating room when the elective cases were closed, except for certain cases. And then once we started to open back to more patients and increase our traffic, how we're going to be doing that re-entry safely, not only for our patients, but also for our healthcare staff. And in a multidisciplinary approach, as different components of this issue affect the different specialties in a different way. So it had to be a very concerted effort. And here at the Institute, where we have a very immunosuppressed patient population because of our cancer patients, we still have all these measures in place. Every day when I come in the morning, they check my temperature. They will ask me all sorts of questions about exposure. Again, all with the main aim to keep the numbers low and everybody safe. And I never thought in a million years that I would be doing visits through telemedicine. But it really helped us bridge a gap when we could only see limited number of patients so that we can continue to provide for the care, even if it's in a virtual manner. So it has been a great adjunct to our tool kit as part of our patient care. And I really had to embrace it because we didn't have too many options. So I feel in a way that I've been reaching out to my patients through my phone and my computer so that I really can attend to their needs. And actually what it did, it helped me stratify in talking to the patients who really needed to be seen sooner or who could wait for the next 6 months visit, who really needed a clinical examination or who needed some added testing because of what they're reporting to me as part of the virtual visit. So it has really been an incredible adjunct. And here we are all under one roof. I'm very blessed to work with a very distinguished group, Dr. Daragopian, Dr. Hiron, Dr. Lopez Penalver, Dr. Mautner, in terms of this is just a surgical team that we have here for any of the needs. And for all of us, I can say one of our top priorities is the patient-centered approach. And I think it's time now to continue to take these small steps that we have been taking over the past 50 years. We certainly see the results in terms of 98.5% survival with early stage breast cancer, which is something amazing, but we need to continue those strides. And prevention is the key in that journey because certainly we cannot let them out of our sight. So check yourselves. Certainly teach your patients to check themselves, know what's normal for you, and ultimately it's time to take a new look, irrespective of where we are. And I think the pandemic has forced us to do that, to be creative and think outside of the box. So I'm proud to be part of Baptist Health and Baptist Health International, so we can collaborate not only here, but also way beyond our doors. We can have the ripple effect of all the things we can do and share our knowledge and experience with all of you here and abroad. So I really would like to thank you for your attention. It's been my pleasure to be part of the special lecture and happy to answer any questions. So thank you for your time. And most importantly, be safe.
Thank you so very much, Dr. Jane Mendez. What a phenomenal presentation. We never get enough of you. You teach us always something in every single one of the conference. As we wait for questions, you mentioned something extremely important, which is 33% of the time, a woman detects something through self-examination. I know that some of our countries, especially in the Caribbean, are challenged perhaps with the access to care or perhaps cultural issues that pertain to the self-need or the self-want of the patient to actually go and perform or conduct an examination, a formal examination through mammography or what have you. Since prevention is key, and you made it very clear, and we know the risk factors in, especially in the Caribbean communities. What would be the knee-jerk reaction to say, I recommend, aside from self-examination, X, Y, Z, in order for them to be empowered and understand that this is true prevention and that ultimately it is in their hand for them to actually identify it early. One thing that is of concern is the fact that Jamaican women nowadays have, breast cancer is nowadays the second leading cause of cancer in women in Jamaica. So how can we bridge that gap?
You know what, I think the key is what Julian talked about earlier, which is making it really accessible and really easy for the women to have it done, like offering free screenings, free mammograms. Certainly make it available to those parts of the island or the country that is most difficult to get a mammogram, or they might not have an imaging center. You know, I know of strategies of having a bus, like a mammographic bus where you have the equipment and the women can go. So make it available to them in their own turf. And community outreach is critical, not only by offering, you know, but also by partnering for people in the community who can spread the message. Because as you alluded to, there's a lot of fears about mammogram in certain segments of the population. And actually in some parts of the world that the women are second-class citizens, they don't even have access to mammography. So is dispelling some of those myths, some of those fears, and some of those cultural biases, and really empowering women to say that this is something that they can do. It doesn't cost anything. It's within their reach to do it. So I think that's where the main challenge lies.
Yes.
Fantastic.
Hakeem?
There is a question in the chat, and it says, "Good day. Are cysts in the breast harmful?"
You said about breast cysts, are they harmful?
Yes.
Yes. So breast cysts do not increase the future likelihood of breast cancer, but cysts sometimes may become symptomatic. So depending on the size of the cyst, certainly they can be aspirated for symptomatic relief. If they're really small and it's only fibrocystic disease,
Yes.
then it's more about adjusting lifestyle and diet, refraining from caffeine, etc., etc. But disease is and of themselves, simple cysts do not increase the future likelihood of breast cancer. Sometimes you have a complex cyst, which might be a cyst filled with fluid but has some solid components inside. Those might require a biopsy because those are not simple cysts.
I think Ms. Brown has a question. Do you have a question, Ms. Brown? Are you muted?
Dr. Hakeem, my point was that breast cancer is #1 among Jamaican women.
It is. Thank you for, I doubted
Yes.
myself for a second. It is #1 among Jamaican women.
#1.
Yeah, so we have a lot of work to do, but it takes a village, literally and metaphorically. It takes a village to take the message to the trenches.
Mhm.
And, you know, and changing behaviors, which is hard. You know, I can tell you within Hispanic women, and I think also a lot of the Caribbean communities, the women are taking care of everybody. You have the
Yes.
grandma taking care of the grandchildren while the daughter works. So there's
Yes.
something called familialism, which is that the older person is taking care of everybody else and they're not taking care of themselves. So that's something that we have to understand as a culture. And certainly it is through education and empowerment that I think we'll be better able to achieve that.
Yes.
She also was wondering if you can elaborate more in regards to the myths and the risk factors.
Okay. So, you know, I've spent doing this for the past 22 years. And one of my biggest aims is to dispel all those myths, because those myths are really dangerous in terms of, for example, the myth of I don't have a family history of breast cancer, I don't need to worry about it. And also for a while linked to that, there was the myth that, oh, it's only your mother's side that is important. You don't need to worry about your father's side of the family. Well, that's all false. As
Yes.
I alluded to, only 5% of women have a gene where we can identify. 10% is familial. And it's both sides of your family that come, because we are 50-50, your father's and your mother's genes. So we need to know our family history to the best of our abilities so we can, again, take action if we identify any added risk. So that's one myth that I spent the past 28 years trying to dispel, because I can't tell you how many women come and they tell me, oh, why me?
Yes. Yes.
I never thought it would happen to me. And then I say, you know, remember the two main risk factors, being a woman and getting older.
Yes.
That's it. You don't need to have anything else. And actually I had a lady earlier in the week, and on top of that, she had been on hormonal replacement therapy for 20 years.
Oh, Lord.
So
Wow.
I said, you have a perfect triple storm. So again, these are the issues that we have to educate. It's a very important component. I'm happy that through your society, you're doing a lot of that education and that empowerment.
Yes.
Because it doesn't matter where you are around the globe, you need to get to the women themselves so that they understand why it's so important for them to take action.
Yes.
And another myth that I didn't include, but is fairly common, is women think that if they have too much radiation by getting their mammograms every year, they have an increased risk of breast cancer. And that is false. You know, they've done studies looking at that. The amount of radiation that we get exposed to when we get our mammograms is minimal. And even now with the computerized 3D technologies, very little amount of radiation. And when you even add all of that radiation over your lifetime, the likelihood of not finding a cancer is much worse and much higher risk than the amount of radiation that you might be exposed to during your lifetime. So that's one that I've also spent a great deal of time trying to dispel.
Yes.
Dr. Mendez, there is a question in the panel and it says, what can you tell us about metastatic breast cancer treatment like Lynparza? Can you explain what a typical doctor hyperplasia means? And if you have this in someone at a high risk of developing breast cancer?
Okay, so the first question first pertaining to metastatic breast cancer. So metastatic breast cancer has become more now like a chronic disease. You know, a lot of women with breast cancer are living very long lives and they develop distant recurrence, you know, most common site being the bone. And we have great strategies that we can use to keep those patients with metastatic disease or stage 4 with good quality of life, with different medications, depending on, again, the type of breast cancer that they have and their receptor profile. So, and the number keeps increasing to the extent that this year alone, I guess, I've had already 3 invitations to talk to women with metastatic breast cancer, because it really has grown as a subgroup within the breast cancer survivorship group that needs special attention. Because certainly if you have it in your bones versus your liver versus your brain, there's different strategies that we have to help you keep that at bay with maintaining your quality of life. So I'm happy to know that they're increasing in number because it means that we have more advancements. Pertaining to atypical ductal hyperplasia, that is a high risk condition. So that would be one of those pathologic conditions that if we get it detected on a needle biopsy, will actually require surgical removal so that we make sure that there's no underlying cancer. Once we have that lumpectomy performed and there is no evidence of cancer, then we would keep those patients on an increased surveillance, because we know that atypical ductal hyperplasia increases their future risk of breast cancer 4 times from that of somebody in the general population who didn't have those atypical cells. Same would apply to atypical lobular hyperplasia and other pathologic condition, which is lobular carcinoma in situ, which has a much higher risk also of developing breast cancer in the future and is considered a risk marker. So all these pathologic diagnoses would render enough risk that these patients would be candidates, for example, for a breast cancer prevention clinic. So we can build for them an increased surveillance program. There's also strategies that we can use, so it's called as chemo prevention, which is the idea, since we know they're increased risk, giving them a medication such as tamoxifen or valoxifen so that we can prevent them from getting breast cancer. And we know those strategies can work very well. Again, there's risk and benefits associated with everything, but those are some of the strategies that we discuss with these high-risk patients.
Amazing. What would you recommend for a menopausal woman who is taking a hormonal replacement therapy, since it is not
Hot topic, and no pun intended. Hot topic, literally and metaphorically. But the issue is that there's other strategies that are not hormonally based that can be tried to treat with the postmenopausal symptomatology. We know that some antidepressants in lower dosages than those used for depression can be effective. We also know that certain antihypertensives can be used on calcium channel blockers. And again, short course of treatment will be okay, but anything 5 years plus is very questionable because we know of the link. So it's a conversation with either your GP or your gynecologist about what type of symptoms you're having, to see what type of strategies that are non-hormonally based that you might be a candidate for, and have that conversation. But knee-jerk reaction, hormonal replacement therapy, again, if it's brief, no problem. But the chronic use is where the problem lies. And again, when I have this conversation with the women, they start to look at me like I had like two heads or three eyes, because who doesn't like to feel younger and have better bone density and have great skin from the hormones? Who doesn't? But it comes with a price.
It does indeed. What can a woman with fibrocystic breast disease do to decrease the breast pain and the chances of getting cancer?
Fibrocystic breast disease does not increase the future likelihood of breast cancer. But however, we know that the breast density lowers the sensitivity of the mammogram. So that's why if somebody has dense breast, they should be considered also for ultrasound, so that we can further evaluate the breast, because we know the mammogram does not work as well as the breast density increases. But there's no link between breast fibrocystic changes and increased breast cancer risk.
I love this following question. It says, my sister's aunt had breast cancer, which metastasized. My sister had a mammogram in her late 20s because of family history. Would you encourage other young women to do the same?
No, mammogram is useless in younger women, again, because of the breast density. The younger we are, the higher the breast density. But yes, what the woman in their 20s should do is, number one, know what's normal for them, be familiar with their body. Number two, know their family history. And indeed, they have increased risk factors based on the family history. Then they should have the conversation with their primary care physician or their gynecologist to see what else they can do besides those two things. Sometimes, as indicated, depending on the factors, again, they might be a candidate for genetic testing. Number two, they might be candidates for ultrasound, which is certainly the preferred tool in women who are less than 35. And ultimately, if they have really high risk and it's in excess of 20%, they might be a candidate for an MRI as a baseline. So again, there's different options available, but mammogram would not be the right answer because it really won't offer much because of its limitations with the breast density.
What about taking tamoxifen as a preventive treatment, considering high risk due to family?
That is one of the alternatives. However, and actually I participated in the first breast cancer prevention trial in the United States, that is circa 1996, that ultimately was published in 1998. And we know that tamoxifen works as a chemo prevention strategy. We know that it reduces the likelihood of breast cancer by 50%, that it be on the affected breast or the contralateral breast. However, there's many side effects. So when you are going to request a woman to take a pill to prevent the risk, but then they listen that it has 1% risk of embolic events, that it can increase the likelihood of uterine cancer by 2%, and they will put them into menopause with hot flashes, weight gain, mood swings. It's a really hard sell. So we have in our clinic, that's one of the strategies that we discuss with the high-risk patients because we know it works. And then the second drug that has been approved for that purpose is the raloxifene, otherwise one known as Evista, usually used for the treatment of osteoporosis, but that has also been approved for the chemo prevention purpose and has a slightly different side effect profile as compared to the tamoxifen. So again, we have these options. It's a lengthy conversation. And at the end of the day, the patient will decide what is best for her and her health.
hot topic indeed. Actually, there is another question in regards to tamoxifen. How long would tamoxifen typically be prescribed for in a patient that has a confirmed ductal hyperplasia that has had a resection of a lump? Would it be safe for a patient who has had a lump removed from her breast as a result of ductal hyperplasia have a breast lift and implant?
Well, we know that if there was no atypia, I really wouldn't see the need to be on the tamoxifen, and it's usually recommended for 5 years. That was the duration of the treatment in the study. So that's usually the recommended length of time. Again, this is a very prolific area of research as well, because we know that there's so many side effects associated with it. But unless there's any atypia, again, it could be that it's a strong family history and the risk is in excess of 20%. But other than that, I wouldn't recommend taking a medication unless we really know it's going to benefit the patient.
Let's go ahead and take a couple of questions more, since just to be considerate to you and to our audience. If the ultrasound is supportive for diagnosis with the mammogram for women with dense breast tissue, would it be safe to just do the breast ultrasound?
No, because the ultrasound is not a screening tool. It is extremely operator dependent. And if done properly, it's really extremely time consuming. And actually, I know some places, and in the United States, many states require that the women get informed of their breast density, because again, we know that the mammogram doesn't work as well, and they give them different solutions, i.e. doing an ultrasound. So they even have in some places robotic ultrasounds so that they do an assessment of the whole breast, but that is not the gold standard. The gold standard is mammography up until we have a better alternative.
One last question. It says, what is the difference between MRI guided biopsy versus a core biopsy?
Well, core biopsy is a type of biopsy that can be performed, and usually we perform the core biopsies depending on the modality where we best see the abnormality. For example, if we see the abnormality only by MRI, we're going to do the MRI guided core biopsy. If we see the abnormality by ultrasound, we'll do the ultrasound guided core biopsy. And if we only see it on mammogram, there will be a stereotactic guided core biopsy. So core biopsy is just the tool, and then we do it with the modality where we best see the issue, so that then we can tackle it. Because obviously, neither of the studies is perfect. So sometimes we can only see an abnormality on the MRI, and that's how we have to do the biopsy.
Mm-hmm. Wow, incredible challenge you have at times with patients that come at a later stage in their disease. And I commend you for all you do for our patients, Dr. Mendez, and I mean that. Unfortunately, we have to let you go simply because it is getting late for you and for our audience. I want to thank you once again for allowing us the time to listen to you, to this wonderful lecture. And special thanks to the Jamaican Cancer Society for the invitation and for hosting us today. Thank you once again. Have a phenomenal evening. Please be safe, as Dr. Mendez says.
Thank you, everybody. Thank you for your time. And
Thank you, Doc.
Thank you, Julian.
You're most welcome.
Thank you for having me.
Thanks, Dr. Hakeem. You're most welcome anytime.
Thank you.